Check. Good evening, everyone, and welcome. We are so glad that you have joined us for the Next Generation Medicine Summer 2025 lecture, focused on one of the most urgent public health issues facing our region, fentanyl and methamphetamine, how these drugs are impacting our community and what we can do about it. We are honored to have two experts joining us tonight, Dr. Caleb Banta-Green from the University of Washington and Dr. Amy Burns from Providence here in Spokane. My name is Robin Pickering, and I serve as Professor and Chair of Public Health at Gonzaga University. I'm thrilled to welcome you on behalf of the University of Washington Gonzaga University Regional Health Partnership. This partnership is built on a shared mission to improve the health of our region, not only through education, but through community engagement, collaborative research, and innovation in care. Together, the UW School of Medicine and Gonzaga are preparing the next generation of healthcare professionals, equipping them to lead with compassion, integrity, and scientific rigor. We are better when we work together as a community. Our work is rooted in commitment to address the most pressing health challenges in Eastern Washington and beyond, whether that's reproductive health, mental illness, substance abuse, which we are here to discuss tonight. For example, as part of our partnership efforts this summer, Dr. Sarah Matusik is working with UW medical students and GU undergraduates on the McKinstry Fellowship Project at rural hospitals, with you, I think, in Newport. Yes, to examine how co-occurring mental illness and chronic disease affect hospital outcomes and how we can build support together, both for patients and providers. Dr. Clint Wutzke is leading a research project that examines how cognitive function impacts balance and movement in individuals with Parkinson's disease, all while mentoring students from both UW and GU in a truly interdisciplinary learning environment. These kinds of collaborations are exactly what makes this partnership so powerful and so essential for the health sciences community in Spokane, in addition to the type of events that we are here for tonight. So once again, thank you for being here. I'm now pleased to turn the podium over to Dr. Jeff Jones, who will introduce our presenters. Thank you.
All right, thanks. Welcome again, and thanks for coming. I'm Jeff Jones. I'm a family doc up in Newport, and I'm also the Assistant Clinical Dean for Spokane and Eastern Washington. I'd like to thank our sponsors, Providence, Multicare, Spokane County Regional Health District, Spokane Medical Society, and the UW Population Health Initiative. We really appreciate your partnership in this event tonight. So tonight, we're honored to bring back Dr. Caleb Banta-Green from the University of Washington for an update on this critical issue affecting our communities. Dr. Banta-Green is a highly regarded expert in substance use disorder treatment and other interventions. Dr. Amy Burns is a Spokane-based psychiatrist also with expertise in addiction. Together, we're going to discuss available services and intervention to prevent serious health outcomes and how to support ongoing health and recovery, including ways family and friends can help support and help with addiction. So kind of the way this is going to work tonight, Dr. Banta-Green is going to present first for about 25 minutes. Dr. Burns will then come up and speak for a little bit, about 25 minutes as well. And then there'll be time for a Q&A session to follow after that, and I will try to moderate that as best I can. So about our presenters, Dr. Caleb Banta-Green is an epidemiologist and is the director for the UW Center for Community Engaged Drug Education, Epidemiology, and Research, which looks like it's abbreviated CEDAR. Do you acronym it like that or just CEDAR? Okay, that's a good one. All right. It's at the Addictions, Drug, and Alcohol Institute, ADAI, and is a research professor at the UW Department of Psychiatry and Behavioral Science. He's also an affiliate professor at the UW School of Public Health, Department of Health Systems and Public Health. His main area of research is on substance use, especially substance use disorders involving opioids and stimulants, and interventions to support recovery and reduce substance-related harms. He's particularly interested in developing interventions that are accessible to all people, including those who are most marginalized, such as those who are unhoused, utilizing harm reduction strategies, and/or in the criminal legal system. He provides technical assistance and evaluation services for public health and safety interventions, including the website stopoverdose.org. I bet most of us have probably heard of that one. And then information to the general public and professionals about effective treatments at learnabouttreatment.org. So Dr. Banta-Green reports on drug trends across Washington state. He has been the Seattle area representative to the National Institutes of Drug Abuse, Drug Epidemiology Work Group since 2001, and partners with state and local agencies on drug epidemiology tracking and reporting. Dr. Burns is a founding faculty member of the psychiatry residency here in Spokane. Yeah, I know, right? Yay. And which was built to address the shortage of mental health and substance use treatment for providers in Eastern Washington. As a side note, we had, I think, 9 of our UW students match into psychiatry this last year. It was a great match for the UW. Yeah, we like it. She's also served as the associate program director for the residency program in Spokane, the medical director of the Spokane Teaching Health Clinic, where she leads the addiction medicine training and clinic. She is board certified in addiction medicine and is a board member of the Washington Society of Addiction Medicine. She graduated from the University of Kansas School of Medicine and completed her psychiatry residency at the University of Washington. So please join me in welcoming first Dr. Caleb Banta-Green and then Dr. Amy Burns.
Good evening. Thank you all for being here. I'm going to be doing this a lot tonight, so hope I brush the back of my head, not just the front. So I'm really happy to be here, and I appreciate the invitation, and I appreciate Gonzaga hosting us, and I really appreciate Dr. Burns joining me, so thank you. We'll see if this works. Yes. So this slide I can tell you without looking at. We both want to report no conflicts of interest. We will be talking about some medications, and so I want you to just be aware we have no conflicts of interest. Do not take funding from pharmaceutical companies. So we're going to talk about fentanyl and methamphetamine. What are they? What are the motivations for use? What are the health impacts of them? We're going to talk about opioid and stimulant use disorder. What are they and what are the treatments for them? And we're going to talk about how to prevent harms and how to access services. And then we'll have some time for discussion. Okay. So fentanyl, what is fentanyl? You've probably heard a lot about fentanyl. Just starting with the basics, it is an opioid. It has similar properties and binds to opioid receptors when you think of things like morphine and oxycodone and hydrocodone, OxyContin, Percocet, Percodan, Dilaudid, a whole array of things that you've all probably heard of. Fentanyl is one of those compounds. And on the left, you can see actually a patch form, which is for severe pain. And we'll talk more about this in a moment, other indications for its use. But the reason you've all heard about fentanyl are the illicit forms of fentanyl that are being synthetic drug that is getting manufactured, a lot of it down in Mexico, often with precursors from overseas. It's very, So I've been doing drug epidemiology for 24 years. Things used to change every 5 to 10 years. Now they change every few weeks. It's dramatic what's happening. And so what you see here in the blue pill here is an M30. It looks like an M30. It looks like a Mallinckrodt 30 oxycodone tablet. It's not. Basically, if you buy one of those on the street, you're about 100% sure it's going to be fentanyl. You don't know how much fentanyl. You don't know what else is in it. But generally in those tablets, they're about 2 milligrams of fentanyl on average out of a 100 milligram tablet. To share with you, I'm giving you a lot of detail, but I think it's important. You may have heard DEA talks about 1 pill can kill. They talk about that because on average, 1 milligram of fentanyl for a person who's not tolerant to opioids can be a lethal dose. On the flip side, a person who is tolerant on these substances might be using 300 of these pills in a month. Both of these things matter. It matters that a person who's not used these could take one of these and overdose, but it's also just as important to understand that's not the target audience. The target audience for this are the people who are using 300 tablets in a year, and in a day, 300 tablets in a month. And what are we thinking about the services for those folks? So if we're thinking about how to reduce the need for fentanyl in our communities, illicit drugs, we're really looking at the folks who are using these many times per day. On the right-hand side, you're seeing a powder or crystal form. This is actually from an overdose death in a Seattle area that this drug was taken from. And on the right side, you can see a long list of compounds that were present. Fentanyl was one of them, but so too were another 10 substances. And what we see in the powder and crystal forms of fentanyl is I've seen a range from 1% to 77% fentanyl. That's a massive range. So if you think about a beer being 6%, well, what if it's actually 100% and you didn't know that? So there's a huge range, and that's part of what makes it so dangerous. So thinking about the properties of fentanyl, it's much, much stronger than other opioids. It's about 50 times as strong as heroin or 100 times that of morphine. It's very, very fast acting, seconds instead of minutes, and it's very short acting, also seconds instead of minutes. And its typical forms that it's used, often intravenously for surgeries, that's where we really think about that very short impact. In a patch form, it's much longer acting, but we're really thinking about this sort of rapid form that's either smoked or injected. It has this very short effect. And that matters. Those properties of the drug are extremely important because that increases addiction potential and risk. A faster onset, a really high high, and a short duration is very priming for addiction. And that, combined with the extremely unknown potency or whatever products are in there, makes it a very, very high overdose risk. On the left here, I have a couple of the flyers are out back around some of the description around fentanyl and harms and trying to understand that and also what folks can do about that. And we have some more information on stopoverdose.org. There's a lot of questions around fentanyl. People have a lot of fear of fentanyl. I think it's better to be informed than fearful, to have good information, because people really can take charge and make themselves safe if they have good information. So I encourage them to take a look at our webpage there. Okay, I'm going to have to stand over here a little bit. So a lot of what we do in our work is ask people who use drugs what's going on and what do they need in their life and why are they using drugs and what supports do they need to make them healthy. Are there things they want to do to reduce their use or stop their use? So a lot of our work is actually just talking with folks who use drugs, and that is essential. It's very easy, as someone who works in public health and medicine, for us to come up with our expert ideas that work really well in our systems that are completely inaccessible and not useful for folks who are actually living these lives. So what we talk with folks who are using fentanyl, what do they need? A lot of it's basic needs. And it should be really clear that we think about a person who's using drugs, well, that must be the most important thing in their life. That might be number 7, right? There might be all the reasons that they're using drugs, whether it's trauma, lack of housing, their partner's using, all these other things are much higher priorities than actually stopping drug use. In fact, using drugs is what allows them to sort of tolerate life. So we need to understand the motivations for why people are using drugs. And you can see some of the various reasons here. We generally see about 70 to 80% of people who are using fentanyl or previously heroin say they want to stop or reduce their use. That's a very different question than do you want treatment? That's with a lowercase t or an uppercase t, that is a whole other thing. But what I care about is do people want to stop or reduce their use as an engagement point? We can talk about that. And then I like this. So this is a quote from one of our folks. Like the general vibe of what ideal treatment would look like is that it's a place of acceptance and love. You don't have to hurt to go there. You're safe here. That's so important because as I've learned so much from some of my colleagues here around stigma, so much of what they receive back when they go to seek care is a lot of punitive language, a lot of punitive actions that actually induce harm and induce trauma, and really trying to think about how do we undo that and actually invite people in. So switching a little bit to describe a bit about methamphetamine, a very different compound. It's a stimulant. It's a very, very potent stimulant. It's actually prescribed as a Schedule II drug. It's digoxin. It's used for weight loss. So people think about methamphetamine as like this strange thing over here. It's not this strange thing over here. It's a pharmaceutical, and it's related to amphetamines, which are widely prescribed and widely used by fighter pilots. So like people use these substances. It's not a strange thing that people use these substances. And with methamphetamine, people often are using methamphetamine for years, if not decades. The same thing with opioids as well. More challenging with fentanyl, given the unexpected potency and such. It's hard to have a long duration of use, but we definitely see that with methamphetamine. Much stronger than cocaine, lasts much longer than cocaine. And again, it's also it's giving you a huge dopamine hit. It makes you feel great. Makes you feel really good. It's a mood enhancer. It gives you a ton of energy. It's an appetite suppressant. A lot of people would benefit from that. A lot of people like that, whether they're just going about their life, whether they're working multiple jobs, if they're unhoused, just whatever's going on. There are a lot of kind of positive reinforcers. There are a lot of functional benefits that methamphetamine can give folks. They're not using methamphetamine because they're bad people making bad decisions. They're using it because it's giving them more benefit than harm in the context of their life. And understanding the context of their life is essential to know how to actually engage and provide them services. So most of the methamphetamine we see nowadays is coming up from Mexico. Back in the day when I started in 2001, it was all Sudafed. It was getting locally manufactured. And I'll note, back in 2001, and this will come up later in a little bit, methamphetamine has been endemic. It has been a major drug in Spokane, certainly since 2001 and well before that. And it matters for something I'm going to talk about in a little bit. So methamphetamine has had a long, long history in Spokane. And back then, we were seeing far more stimulant methamphetamine overdoses than we were heroin. We do a project called community drug checking in a few places around the state, and what we generally see with methamphetamine is it's usually methamphetamine. And if you're interested in seeing some more of those results, you can see them on our webpage. So the challenge is that when it's sold as methamphetamine, it's usually methamphetamine. But if someone gives you a powder or a crystal and you don't know what it is, or you find it or you come across it, then you're really in trouble, because you don't know what it is. And that's where you start hearing about folks who didn't mean to take fentanyl having a fentanyl overdose. They thought they were using cocaine, but it was actually fentanyl. And for a person without opioid tolerance, actually taking fentanyl can be very dangerous and in fact deadly. So a little bit here, just to let you know, we have really rich information I encourage you to take a look at on our webpage. We have some of the qualitative data I've just mentioned. We also do a syringe services program survey. We've been doing this statewide since 2015. The Spokane Regional Health District, their syringe services program has been part of that survey. I hope some other community partners are going to start doing that as well here in Spokane this fall. And these are really, really rich data that help inform our work. We get about 1,600 surveys from 25 syringe service programs or harm reduction programs across the state. And if you want to understand more about what's actually going on around substance use and in the context of people's lives, I encourage you to take a look at that. We've also been doing increasing work with folks in permanent supportive housing. It's a place of actually an opportunity for really great services, but also can be a place of great hazard for folks who might have been living and using in a communal place and are now alone in an apartment, and it actually can induce harm for them if we aren't giving them enough services and supports and socially connecting them to other folks. So it's important to think about that population of folks who are new to housing is actually a very vulnerable time for people. So some of the information we got from our qualitative work with folks who use methamphetamine, what we see with methamphetamine is interesting. As I mentioned, about 75% of folks who use opioids say they want to stop or reduce their use. Generally, when it comes to methamphetamine, it's more like 50%. And part of that is for opioids, people are mostly, once they're really tolerant on opioids, they're mostly using to not feel bad. It's a negative reinforcer. So if you, and we'll talk a lot about this, if you can get a person on a medication, then they're good. They've avoided that negative state. They're on a medication that helps them feel what feels to them normal. For methamphetamine, it's giving them a lot of positive benefits in their life that's allowing them to function. And so wanting to stop use is often not the first thing they want to do. It might be the ninth thing they're able to do. So it's important to recognize that, because if you're coming to a person and leading with, we got to get you in treatment, they're like, no, you need to stop using methamphetamine. No. They want other things. There are other things we'll talk a lot about that we can offer to people, but leading with treatment and leading with stopping use is less likely to be very productive with folks who are using methamphetamine. And that's important because that's our default. That's what most of us think is normal or typical or we're trained in. So reasons to cut back or quit are a lot of these things are around like family and relationships, desire for a normal life, physical health, mental health for sure. What would help? A lot of the things people want, again, not about treatment, are about relationships and social connections, support groups, a lot of personal things that people want, housing, and medications for mental health are a big deal, and I know Dr. Burns will talk about that. The intersection with mental health for folks generally, whether it's opioid use disorder and or stimulant use disorder, is very high, and we want to help support people in both of those areas of their health. So implications, I mentioned most folks don't want treatment. Often addressing the psychological issues and the motivations for use are really where we're going to get a lot of traction and a lot of engagement with people. Mental health, relationships, social networks, decreasing chaos often is a great starting place for folks. They don't want to be in that chaos. They identify it as chaos and they don't like it. And there's a lot of different aspects of their life that they could use help and support in. And again, it may be that once they get some stability and restoration of functioning in those domains of their life, then they can start having a conversation about reducing their methamphetamine use. That may be coming months or even years down the pike. So health effects, and hopefully Dr. Burns can fill in more here later. The health effects for opioids are in some ways fairly narrow. Tolerance or withdrawal, that's something that everybody gets if they take opioids for a period of time. Opioid use disorder, some people develop opioid use disorder, not everyone. Overdose risk is a very real concern, and infectious diseases, particularly related to injection, but also sharing other drug-using equipment. But people like to joke, like Keith Richards is a great advertisement for heroin. That's not quite true, but good, clean heroin for many years for a person who's healthy and has good social resources is a sustainable thing. It is not as hard on your body as methamphetamine is, and that's an important thing to be aware of. This figure here is from my colleague down in San Francisco, Dr. Philip Coffin, and there are a lot more health impacts that we see with methamphetamine. And these matter, all of these health impacts of methamphetamine, they can accumulate over time, and I think they're really leading to what we're seeing in terms of the increase of methamphetamine-related deaths recently, which I'll talk more about. Okay, so this is looking at Washington State poisonings or drug overdoses over the last while. And what you can see is we've had a huge increase over time. The black line is all drug-caused deaths. Red are those involving opioids. Most involve other substances as well. The dark blue is methamphetamine. The light blue is cocaine. And we've seen a huge increase, particularly driven by fentanyl for sure, but methamphetamine has certainly come along for the ride. And as I'll talk about in the next slide, about 3/4 of those methamphetamine-involved deaths also involve opioids. And you'll see we've seen a bit of a dip in the last year. And there are good and bad reasons for that. There are good reasons in that we're really ramping up a lot of our services, as you'll hear more about. We have really effective treatment medications for opioid use disorder, methadone and buprenorphine. We're doing more and more to get those more accessible, to get people on proper doses quicker, to keep them on those medications and keep them engaged. And those are certainly having positive impacts. The downside of this, the bummer, the really sad part of this is we also have what we call an epidemic curve, where that line can't go up forever. It's not a thing that can happen. At some point, it has to apex, plateau, and even begin to decline. And that's because so many people have died that we're actually seeing them dying off of that population. And I think we're seeing that in particular with stimulants in the local area, and I'll talk about that in just a moment. So this is looking at methamphetamine-involved deaths over time. What you can see on the left side were much lower rates, and you can see in the blue shading were methamphetamine deaths without any other drugs present. Back in the day, those deaths involved just methamphetamine. The minority involved opioids, and that's really flipped, where now most of the deaths with methamphetamine involve an opioid, and that's really driven by fentanyl. And what we see when we work with medical examiners and toxicologists is those opioid plus methamphetamine overdose deaths, they really look like opioid deaths. They look like opioid overdoses. The characteristics are very much like an opioid overdose. But with methamphetamine, it's quite different, where the drug use might have been hours, if not days ago, as opposed to with opioids, it's often minutes before a death occurs. So we're seeing that this methamphetamine use has a longer trajectory. It's further back in time oftentimes. And we're often seeing really advanced cardiovascular disease, even in fairly young folks. So we have a couple dynamics going on, we think, which is we have this aging cohort of folks. As I mentioned, methamphetamine's been around for a long time. Some of these folks who are dying may well have started using 20 or 25 years ago, and their heart just can't take it anymore. So we have this aging cohort, and we have a lot of underlying health conditions. So it's kind of a technical thing. They may be less overdoses. It's not actually an overdose. It's not more drug than a body could handle that day. It's quite often where the cumulative effects have caught up with that person that day. And there's some additional load and stress that the methamphetamine is putting on their body that day for sure, but we're often really looking at underlying heart conditions. And that matters because if we want to prevent those deaths, we need to get upstream and be providing primary care and heart health and doing these other things. That's the implication. So it's not just like, oh, isn't that interesting? It's not just interesting. It has profound impacts for where and how we provide care and what that care looks like if we want to be preventing these deaths. And let me show you what we're looking at in Spokane County. So on the left side, these are this is opioids. This is Washington State. We do 3-year averages just to smooth things out. What you can see is that for 2022 to 2024, the death rate for opioids was 30.7 in Washington State. It's actually 37.6 in Spokane. So we had a higher opioid overdose rate in Spokane than we saw statewide. And you can see a huge increase, which we've seen across the state as well, a more than 3-fold increase over this period of time. So here you see this rate for opioid overdose deaths in Spokane at 37.6. That's almost the same as methamphetamine. So you have almost the same methamphetamine overdose rate as you do opioids. That's not what we see in the rest of the state. You have a higher methamphetamine overdose rate in the state at 36.8 compared to 24.7 for the state. So you see a higher overdose rate and a huge, huge increase over time. So that's the other thing, is that opioids went from here to here, and methamphetamine went from here to here. And we see that particularly strikingly in Spokane. So I think with that, I'm going to hand it over to Dr. Burns to talk a little bit more about all of the terrible things I just told you and what we can do to help folks.
Okay. Okay, so I thought I'd start with talking about the diagnoses of substance use disorders. And so in order to make this diagnosis, it's a clinical diagnosis, which means that we use the DSM to check for different criteria. And so on this screen, we see I have listed the different criteria for the diagnosis of fentanyl use disorder or methamphetamine use disorder, either one. And there's a couple of these that I think are really relevant. The one, like some of them that I think are really important, including the inability to stop or cut down. And so a lot of times people will think, why don't you just stop using, just try harder. But it is a part of the diagnostic criteria that you have an inability to do that. If you were able to do that, you wouldn't have the use disorder. Also notice that the criteria have a lot of social ramifications, where you're dropping the ball on your social, on your family, on your friends, on work, and so on and so forth. So it has huge ramifications for not only for the individual who's going through this, but also their friends and family. And so there's a lot of suffering happening in these people's lives. And not only is it relevant for the individual and their families, but also there's community impact. Here in Spokane, we see a lot of public intoxication, the huge impact on the jail and the court system, police, ambulance, so on and so forth. And I just want to talk about the fact that if people are in treatment and they're in effective treatment, we also see a benefit and a reduction of impact on the community. And so I just want you to think about that as well when I'm talking about the treatments for these disorders. Okay, so I'm going to start off with treatments for fentanyl use disorder first. Okay, going to do a little bit of neuroscience. So keep in mind that each of us have normal and naturally occurring opioid receptors in our bodies. And this is a natural part of our day-to-day existence. So for instance, natural opioids like endorphins, we get a little squirt of them each time you maybe have a really nice meal or you get a really good workout. You'll get a little squirt of endorphins or opioids, and that tickles this reward pathway here. And this reward pathway, it feels good, and so you keep doing the things that feel good. Well, with this use disorders, this fentanyl and other opioids can kind of hijack this system and really maximize the experience that people have. Initially, anyway, and then after they use for a while, it's not so much fun anymore, and it becomes more about avoiding withdrawal symptoms. Okay, so it's these naturally occurring opioid receptors that the treatments for opioid use disorder target. So I'm going to first start talking about methadone. And methadone's kind of like the original treatment for opioid use disorder. We have over 50 years of data talking about its effectiveness at preventing death and mortality from opioid use disorder. This methadone is a full agonist, and what that means is it sits in our opioid receptor and fully activates the system and the receptor. And so what that means at high doses, it could also cause you to have respiratory depression and stop breathing as well. Methadone is available in opioid treatment programs, so methadone clinics, like at the Spokane Regional Health District here in town. These are clinics that are very highly regulated at a federal level, and there's a lot of rules that go along with these regulations. Like frequently you have to show up every day when you first start in order to pick up your dose. Sometimes it's really early in the morning that you have to roll in there, and you may not have a car, and so it just is a lot of challenges to meet these regulations, but it's very effective. This is just a little bit of data to show the effectiveness that methadone has in saving lives. So the green bars are people that are on methadone, and the orange bars are people that are untreated. And these are mortality rates associated with untreated versus treated opioid use disorder. So the top is overdose risk, and the bottom is all-cause mortality. So you can see that people on methadone, it works, it saves lives. Okay, the next drug I want to talk about is buprenorphine. People may know of it as Suboxone. And this is a partial agonist at the opioid receptor, which means it fits in the opioid receptor, but only partially turns on the activity of that receptor. And that's relevant because if it only partially turns it on, we don't see to the same extent the problem of respiratory depression if you took it in overdose, for instance, that it doesn't typically cause you to stop breathing. And so it's a lot safer in that respect. It used to be that you had to have this waiver from the DEA in order to prescribe it, but due to the response to the opioid epidemic, now all prescribers with a DEA license can prescribe it if you feel comfortable. And so what that has done is made it a lot more available to people, so primary care doctors are feeling more and more comfortable prescribing it. It's a lot easier to obtain the methadone, and there's not as many regulations around getting it, so you can get it from your primary care doctor or a lot of places, anywhere a prescriber feels comfortable prescribing it. But with that being said, there's still some barriers. Not all prescribers feel comfortable doing it. You have to have an appointment a lot of times, so there's still some access problems. Buprenorphine comes in many different forms. The original formulation is called Suboxone. And it comes as either a film or a tablet, and you put it under your tongue and let it absorb under your tongue. And if you were to swallow that thing, you wouldn't absorb it. And so it's only absorbed through your mucosa or the skin in your mouth. It's also available in a long-acting injection, and these are pretty cool. They're called Sublocade or Brixadi, and they come in either a weekly formulation or a monthly formulation. And what you do is you just get an injection either in your arm, the top of your hip, or around your belly button, and the medicine slowly releases from this little injection site, so that way it kind of protects you for up to a month. So that's one of the advantages of buprenorphine, is it has this long-acting injection. Similar to methadone, buprenorphine has great outcomes in preventing death from opioid use disorder, but it has some advantages, being that it is more accessible and less regulations in order to access it. The next treatment I want to talk about is naltrexone, and this is an antagonist at the opioid receptor. So this sits in the receptor and blocks the activity. It's available in a tablet that you take every day or a once a month injection. One of the challenging things about getting patients onto this medication is that you have to go through opioid withdrawal in order to get ready to be on it. Because let's say you had opioids in that receptor and this kicked it out, it would be very painful withdrawal. And so in order to prevent that, we let patients go through make sure that they don't have any opioids in their receptor when we start them on this medication, because that would really hurt if you did it abruptly. But the problem with that is when you're going through that period of waiting for the receptor to be empty, it's very high-risk time for overdose, because you're really craving and not feeling good at all. And so it's high risk for overdose during that time period. Also, once people get on this treatment, for a variety of reasons, discontinuation rates are a little bit higher for naltrexone than they are for methadone or buprenorphine. And so naltrexone is a really good choice for people that are highly motivated and are already detoxified. This is something that I don't know is well known, and I think this is an important piece of information that all of us can get out into the community, and that is that stopping treatment for opioid use disorder, like if you are currently on buprenorphine or methadone and you were to quit taking that treatment because you're feeling like, I got this thing in the bag, I haven't used in a minute, I don't really need this treatment anymore. When we look at those patients, we see that more than 80% of them have relapsed by the 1-year mark. And so we know that this is a relapsing illness. And so when you're on treatment, it's important that you stay on treatment, because we know that there's a really high risk of relapsing when you get off. And the thing is, when you get off of these treatments, your tolerance is really low, and the potency of the street drugs have gotten higher while you were gone. So it's like a perfect storm, And so it's for this reason that we recommend people stay on treatment. Oh, and then I just also had another point on here about the mortality risk rises 6-fold after you stop treatment. And so that just kind of points out to that risk of tolerance and potency together. And the first month after you stop is the highest risk for that mortality. Okay, so there's a lot of non-pharmacologic treatment for opioid use disorder, like motivational interviewing and CBT and residential treatment and so on and so forth. And those treatments are great, but their effect sizes or their efficacy at keeping people alive isn't as great. And so we know that the medications for opioid use disorder are more effective and have better outcomes than the others. With that being said, adding those non-pharmacologic strategies to the is even better. There's a lot of barriers to treatment for opioid use disorder, and Caleb talked about a lot of those, but I wanted to highlight a few of these around internalized stigma and stigma from society, as well as knowledge gaps and misconceptions, because I think tonight in the room we can do something to address those. And if you guys can share them with your friends or your family members, I think we'll be able to make some progress. Ooh, tricky. Okay, so the first misconception that I want to talk about is this sense that if you're on treatment, then you haven't really kicked your addiction, and that if you're on buprenorphine for opioid use disorder, then you're still addicted. And I just want to point out that people that are on buprenorphine no longer exhibit the behaviors or symptoms or criteria for opioid use disorder that they had when they were actively using. And so I guess, it kind of makes me think about people who say, well, I'm addicted to exercise, or I'm addicted to eating kale or something like that. I mean, you can get addicted to all kinds of things, but I would say that this is definitely a healthier way of living your life, no longer meet the criteria for opioid use disorder on this treatment. Okay, another misconception is that people shouldn't relapse. Like, once you are on this treatment, you should just be able to strong arm this and keep consistent with your treatment plan. But keep in mind that we are all human, and along with all other health-related behaviors, similar to like hypertension and your treatment, taking your medicine for your hypertension, or staying adherent to your diabetic diet, we all fall off the wagon. And like, think about, it'd be kind of like saying, somebody showing up with a heart attack and then blaming them for the French fries that they ate. Do you see what I mean? Like, we are all doing things that we know we shouldn't be doing, and that this is a relapsing illness, and we all just need to prepare for the relapse and know that it's going to happen. The third point I want to say is that treatment is easy to access. And while we've made a lot of great progress, it's still kind of hard, because the thing is that when you want to get onto buprenorphine, may not be the time that there's a clinic appointment available. And you're like, there a lot can happen between when you schedule the appointment and when the appointment actually comes, and you may not be in a place where you can get to that appointment at that point, because maybe, who knows what's going on, because these people have really chaotic lives. And so King County has an incredible program that I think could be beneficial in our county too, where there's a 24-hour 7 days a week, 365 phone line, and you can call, and a prescriber will make a prescription for buprenorphine over the telephone at any time that you're ready to stop, rather than when the providers are available. And I think Caleb said that there's a chance that that might be going statewide, so I'm hoping that that would be something that could really help rural community providers too. Okay, so takeaway points. Methadone, buprenorphine, and naltrexone reduce relapse and mortality. The non-medication treatments are helpful, but not quite as effective as the medications for opioid use disorder. You can be in recovery on methadone, buprenorphine, and naltrexone. You don't have to get off of these medications in order to live an effective life. Relapse is expected, and we should plan on it. And barriers to treatment still remain. Okay, now I'm going to talk a little bit about methamphetamine use disorder treatment. There's a lot of different aspects to methamphetamine use. First, we treat the methamphetamine use disorder itself, but then we also need to focus on the other conditions that they may have. A lot of people also have opioid use disorder, so we can start them on the treatment for opioid use disorder that I talked about previously. Then we also need to treat their psychiatric comorbid disorders, because unfortunately chronic methamphetamine use can result in quite a bit of psychosis, and I would estimate about 20% of the patients at the psychiatric unit at Sacred Heart are there for psychosis associated with chronic methamphetamine use. And so it's a real issue for our community. We see a lot of people who go on to develop schizophrenia from what we believe to be chronic methamphetamine use. Then there's also just the medical problems that Caleb talked a little bit about, the cardiovascular illness that we need to screen for and treat. So the treatment that we know about that has the largest effect for treating methamphetamine use disorder is a treatment called contingency management. And you probably remember from your Psychology 101 class, operant conditioning. And this is the idea of pairing a behavior, a positive behavior that you want to see, with a reinforcer. And so in contingency management for methamphetamine use disorder, what we do is we pair negative urine drug screens twice weekly, negative urine drug screens with Walmart gift cards of escalating amounts. And so when somebody is demonstrating sobriety from the methamphetamine, they get reinforced. This is an example of a reinforcement schedule that we're using at our clinic. And so you can see that it's not a huge amount of money that patients are earning for their negative urines. And in fact, over 3 months, they can earn $528 for 3 months of sobriety. Now, a lot of people, there's a lot of treatment going on for methamphetamine use disorder, like for instance, residential treatment. And what we know is that contingency management has a lot larger and better outcomes, long-term outcomes from helping. And what I'm trying to say is that people are more likely to stay abstinent from methamphetamine for longer with contingency management than they are from residential treatment. And contingency management costs a lot less than residential treatment. Like for 30 days of residential treatment can cost $1,000 to $5,000, whereas we can get 3 months of treatment for $257 per patient in contingency management. So you may think to yourself, like, why isn't contingency management all over Spokane? And I'll tell you, there's this Office of the Inspector General. And there's some regulatory challenges that make it really hard for organizations to implement this. But we actually have an expert in contingency management implementation in the audience that has been instrumental in bringing contingency management to the state of California and Montana. So I hope that we can do that in Washington State. But it's really hard. Unfortunately, there's no FDA medications for methamphetamine use disorder. While we try a few medications, I'm looking at the residents, we try a few medications, they just don't have the same robust effect size that we see in methadone, buprenorphine, or naltrexone for opioid use disorder. Okay, back to Caleb.
Okay, a little bit more about so what. That was more on the sort of substance use disorder treatment side of things. So thinking about health supports and how we can really coordinate with a lot of other things. Primary care, just general health, we've talked a lot about this evening, is going to be super important. Mental health. Wound care is very, very common for folks, whether it has to do with being unhoused and just general hygiene, or whether it has to do with injecting. We're also seeing some compounds, particularly in fentanyl, that can lead to some wounds. So wounds are a really important issue for folks and are also very stigmatizing. People feel a lot of shame around seeking care when they have wounds. So really thinking about how we can create safe, inviting places for folks and or how we can go out and meet them where they are is really important. Infectious disease testing and treatment, HIV and hepatitis is going to be super important for folks. And then, of course, overdose and infectious disease prevention services are going to be critical. I have this flyer that you all hopefully have that we recently put together. And the idea here is, as long as, I first started working with folks who use methamphetamine back in '96. You guys all have been grappling with methamphetamine for a long time, and yet we really aren't doing much. You saw the scale of what's happening around opioids in Spokane, and what you saw what's happening with methamphetamine. And in terms of actual things to do, it's about 99.9% opioids. And we have good things, and we should do those things, and we should be doing a lot more for folks who use methamphetamine. And so this flyer really walks through, and it really is a health support guide. It's not a treatment abstinence tool. It's a health support guide, and it really starts with how can we engage with folks? How can we understand what their motivations are? What are the things that they're getting out of methamphetamine? What are their concerns about their methamphetamine use? Helping them realize some of the health effects they may be having may be related to the cardiac or brain effects of methamphetamine, connecting those dots for folks. They may not realize that methamphetamine is actually underlying some of those health things. And then really importantly, safer use tips. Most people are not going to stop using now. And it may take a while, and even when they do stop using, they may return to use. And we don't want them to die or get infectious diseases or have overdoses in the meantime. So we need to support safer use as well. And there's a lot of things we can do on that front, and this goes over all of those. On the next page is basically thinking about how we can address the health impacts of meth, that these can prevent death really upstream. And use reduction can take years, and recognizing that. Treatment interest is really often lower, and we need to identify sort of those gaps and such. So we have a long list of things that people can do, and I think of this as kind of like the menu you put in your restaurant window. Look at all the things we have to offer. Hopefully something is appetizing to you. Please come in. Oh, I'm sorry, you didn't like the shrimp? Come back next time and try the calamari. Like, keep coming back. Maybe that's a very strange analogy. I shouldn't have used it. But particularly seafood in Spokane, no offense. Well, lamb, beef. Anyway, I just went sideways on that one. I think really importantly, the real point is we want to keep inviting people back no matter what. That's super important. Whether you're doing great or whether you're not doing great, we want you to keep coming back. We have something else to try over and over. This is trial and error, and let's see what sticks, and let's accumulate wins over time. I think that's super important, is lots of little wins. And building a relationship and people starting to feel some success and some self-efficacy can be super important. So fentanyl-related harms, you've heard about these, but I'll reiterate them because it would be bad of me not to. The biggest thing we can do to have the biggest impact on overdose death and what's happening in our community around opioids is providing unremitting, easy access to methadone and buprenorphine. It's incredibly important. Those are the most effective things we can do. Methadone and buprenorphine reduce mortality at least 50%. I would argue, I don't know if I've seen the data, it's probably closer to 80 to 90% every day that person's actually on those compounds. So we really want to get people on those medications. And great when they also support recovery. So that's super important. Safe for use supplies, we need to reduce infectious disease and wounds and support engagement. And overdose education in naloxone is incredibly important. So many lives have been saved by naloxone. It is more expensive than it should be by far, but it is actually a very, very cost-effective intervention. But if you think you are done by just making naloxone available, you are incorrect. You have a mortality reduction of about 50% with methadone or buprenorphine. It's about 4% at the population level with naloxone. You should absolutely do it. It's totally worth it. You're never going to dig your way out of this hole with naloxone. It's not possible. And yet often I think we sort of pat ourselves on the back that we did something. Hey, we're doing naloxone. Great starting place. What's next? What are you going to do next? And then, let's see if I can get that to work. Oh, I'll go back one more. So this, I'm super excited. This is the book release of this flyer. I just got it dropped off in my office yesterday. I put this together with Dr. Alexis Ball, who is a pediatrician, and Professor Addie Adwell, who's a doctor of nursing practice, and they both work very hard to care for folks, young people with opioid use disorder. And we've been doing a lot of qualitative work with youth and with their parents over the last couple of years. And in some ways, one of the things that for me really catalyzed this flyer was hearing youth tell us that their friends were more supportive of them being on treatment medications than their parents. That's extremely concerning. That's extremely concerning. And it's fixable. And that's really what we try to address. So not just explaining what is opioid use disorder, what are effective treatments, but also explaining practically that most people with opioid use disorder, even when they get on medications, they continue to use opioids some. And it doesn't mean the medications don't work. We need to keep people engaged and staying on those medications over time and really focusing on connection and health and safety. So a whole other piece is about this idea that, there's a lot of confusion, a lot of mixed messages out there about am I enabling them by allowing them to still sleep in the garage? Retaining connection is essential. It is the thing we hear over and over from folks who recover is that someone continue to care for them. You should definitely have boundaries. You should take care of your emotional and physical health for sure, but retaining some type of connection is essential. Because when you break that connection, someone else is going to step in. If your kid's no longer connected to you, someone else is going to come right in and take care of that connection need, and they're probably not going to be looking out for the well-being of that kid the way that you would. So really focusing on connection is super important. So I encourage you to take a look at this and engage with folks and share it with people in your community. So a few other things, maybe Dr. Burns, if you come up here and we can sort of talk about this together, and I know we have some experts in the audience as well. So in terms of accessing care in Spokane, there are some website things that we want to make sure people are aware of. The Washington Recovery Helpline has a really nice locator. You can it's like CarMax, but for opioid use disorder treatment. Seriously, it's pretty good. So I encourage people to take a look at that. There's low barrier drop-in care at multiple places. Bloom Psychiatry is here, working on compassionate addiction treatment, and the Health Equity Coalition. Dr. Nevin's doing a bunch of things with coordinated care, and hopefully folks can talk about that in a moment. What else would you say on the opioid use disorder? And we have opiate treatment programs, including at the Health District and as well as several other places. Ideal options. What else would you put out there?
The Spokane County Substance Use Disorder Resources. This is an initiative by the Spokane Regional Health District, and they're putting a lot of work into updating it quarterly, and so that it's always up to date, and it's for Spokane regional treatment.
And then you had some things you wanted to talk about around methamphetamine treatment.
Methamphetamine treatment. So the only contingency management program that I know of in Spokane for methamphetamine use disorder specifically is at the Spokane Teaching Health Clinic. And I put the phone number up here. We take self-referrals. So that means that you can't call, like a family member can't call and schedule an appointment for the patient. It has to be the patient that calls to schedule the appointment for themselves. And then also WSU Research has a research study going on right now for people that are interested in cutting back on their methamphetamine use that are already on treatment for opioid use disorder. So it's, it's kind of a niche patient population that they're looking for their research study, but still it's a really great resource for contingency management in the community.
Great, thank you.
Rockwood Clinic, okay.
Great.
And are they, Sarah, are they doing methamphetamine only? Okay, so they'll do contingency management for meth only. That's great to know.
Great. And a couple more things, and I'd love to hear others information around resources, but I want to share a little bit more on health supports and harm reduction. Definitely contact these organizations to find out what services they have and what supplies and what the timing is and such, but you can see a bunch of different organizations engaged in distributing naloxone, sterile syringes, safer smoking supplies, fentanyl test strips, other things. And I want to be clear from my perspective, harm reduction is, supplies as part of it, but it really is fundamentally around services. It really is around engaging with people in a non-judgmental way that invites them in and invites them back over and over and over again. The supplies are sometimes the draw that get people there, but it's the relationships that get people to keep coming back. And so it's super important that we actually fund the people that do that work. For decades, harm reduction providers have been doing this for free and out of passion, and they really are vital health services that our communities need to be supporting. We're slowly getting there, but I just can't say enough about how important and how real that is. Those are really important health supports that we need to be making sure that we are supporting. So I wonder that, Sarah, thank you for that around Rockwood Clinic. Are there other things in terms of first just around maybe these particular services, whether they're treatment services, health services, or harm reduction services and supplies? I know we have some providers in the room. Is there anything else that you would like to mention? I think we have microphones. Does anybody want to share things that they're aware of?
Hi, so I work for Maddie's Place. We're a freestanding recovery nursery for infants that have been exposed to substances before birth. What's unique about our program here in Spokane is that we include parents in that model of care. So for parents that are willing to try to get into recovery, they can come stay with their infant 24/7 at Maddie's Place, free room and board. And while our license is to care for the infant and help them through their withdrawal, we have a family advocacy team that wraps around those families, those parents, to help them address literally any barrier they may have to getting into and staying in recovery. So we're operating as a pilot project right now, so we're hoping to stick around for at least another year, but hoping to make this a permanent solution, at least here in Spokane, but also in Washington State.
Great, thank you. Leilani?
Hi. I was just going to mention Deaconess emergency room if for after hours when clinics and stuff aren't open, they can go into the emergency room and get started on buprenorphine and also connect with services. They have a peer with lived experience that works there and also a nurse that works for the state opioid response network. And so then they can get connected to services and treatment and longer term care.
Thank you.
Hello, I'm Kayla. Just wanted to share, VA has a new syringe service program. It's new, like last 2 years-ish, and we're starting to do more outreach with some of our stand downs to like hand out naloxone at stand downs, make sure we're representing as far as availability for substance treatment for veterans, both outpatient, intensive outpatient, residential. We've got programs all across the country for veterans. And there's really a big push to try to make that more accessible. And we also have contingency management at the VA. And then also, as far as in the community, we've got a lot of different partners that are working together, and we're working on kind of to decrease some of the silos between all the different types of care so it's more accessible to our people, our community who needs it. So like harm reduction kind of open clinics. We have one at Bloom Psychiatry that we partner with the medical residents every other weekend, and it's just kind of walk-in to provide harm reduction supplies and offer medication treatment for opiate use disorder to anyone on a walk-in basis. And it's really kind of exciting to see people come in, even if they're not ready, the first 15 times they show up. Sometimes they ask questions about medications and they say, I think I'm ready to try it. So it doesn't matter really how long that takes or how many times we have to do it, but just keeping that door open and saying, how can we help? And then getting them to where they want to be, whatever that looks like for them. And it just makes an incredible difference because a lot of people, especially with substance use disorders, have had a lot of negative interactions, both with the community and with the healthcare system. So it's challenging to be vulnerable to ask for help when they are ready, because sometimes they haven't been treated very well because of whatever is going on in their life, and kind of like they spoke about chaos and different medical issues and mental health issues and homelessness and ongoing substance use, and sometimes it takes a couple times to get it right. So just know there's lots of new efforts kind of in the community and lots of options and opportunities to partner with different programs so that we can kind of as a community pull together to help our vulnerable folks and help them get treatment.
I'm Whitney Aller. I'm a psychiatry resident here in town. I wanted to put in a plug for the SDHC Recovery Clinic also. So we have contingency management at our clinic, but we also have a recovery clinic for people suffering from any substance use disorder. And we provide care for if you have comorbid psychiatric illness in addition. And also for the People's Harm Reduction Alliance out of Seattle, which partners with the Washington State Department of Health to provide free naloxone once a month. So there's a website, it's prha.org/naloxone, and you just put in your address and you can order naloxone sent to your house for free as often as once a month. And it's usually available through some pharmacies. Sometimes you might have to pay for it, but.
Anything else around services that folks want to make sure that people are aware of? Okay. Now opening the door to any questions or comments. Any. You grab a microphone. Thanks.
So for folks with methamphetamine use, or in general, like with having a substance use difficulty, they need a lot of resources, and as you mentioned, homelessness or some difficulty in their life that's pushing them for this substance. And we are seeing a lot of patients or people who are struggling with very challenging life, and we kind of scrapping for very we want resources, we want something to help. If someone is homeless and have a dog, it's hard to find them a place. Or if they have a family, or addition to like in the cold. So yeah, I'm just putting the word out there. It's just like I hope there are more resources, especially for the people who are going through a lot of psychosocial stress, like financially and being homeless, or being from minority community as well.
Yeah, I appreciate that. I think, when you talk with folks who are using methamphetamine who are unhoused, they're often using it to stay safe at night, to stay awake so they aren't victimized, or just to be able to walk all night. And so telling a person who's unhoused using methamphetamine to just stop using methamphetamine is unlikely to lead to much of anything. I freely acknowledge that addressing housing is a big issue, but it is the relevant one. It is the relevant one.
So I'm a municipal court judge here in Spokane, and so I deal with this issue because we do require, as part of probation, that you have to get mental health treatment and substance use disorder treatment. And so as I'm here to learn, and as I'm listening to this approach in the criminal justice system, that's not how we approach it. And so I guess I'm just wondering where the intersectionality is for like how I as a judge can supervise someone that's on probation that's required to do treatment because they have been convicted of committing. I'm going to take away all the sit and lie and the trespasses. I'm talking about like assaults and thefts and things that actually cause harm to the community. I would like to know how there could be some sort of integration of these concepts to increase people's success.
It's a wonderful question, and I'm glad you're here, and I'm glad you asked it.
Yeah.
I'll give my response. I'd love to hear Dr. Burns' response. So when I talk with judges, I'm like, please phone a friend. Please phone a friend who has the subject matter expertise, because that's not your training. You're being told by an assessment this person needs outpatient treatment, and you're hearing Dr. Burns say that is highly unlikely in and of itself to help remediate a person's opioid use disorder or their methamphetamine use disorder. So we're often mandating people to services that are not going to work and then punishing them further for that. That's the reality. I think it's fair to say, and that sets you up and it sets them up. So I would defer to Dr. Burns more specifically on that, but I think that's a fundamental disconnect we have right now with how we're caring for folks who are in the criminal legal system who have substance use disorder.
Yeah, I know a lot of people come and say, as a function of my court, I have to get a CD assessment. And I think that's an ASAM assessment where they tell them like how long they should be in residential treatment and so on and so forth. And the data doesn't really show that being in residential treatment without being on a medication for opioid use disorder is very effective in the long run. And so we need to come up with different system. I don't know how. I mean, I would love to talk with you about how we might be able to do that. Like I could imagine, maybe you guys want to see some urine drug screens with buprenorphine in it every so often, or maybe you want to see the results of their contingency management. I think that there's some innovative ways that might be more effective than what we're doing now.
So phone a friend.
Yeah.
She's got the microphone in the back.
So I heard a local businessman talking about how 30 to 60% of our police and fire budget goes towards dealing with homelessness and some of the outcomes of untreated addiction. And so that's obviously part of our strategy in a community is how we're going to deal with this. We're going to throw a lot of money at our police and fire. How efficacious is that compared to treatment?
I actually didn't hear the very first part of that. So you're saying...
There's a businessman who is on a podcast, local, highly respected person talking about the crisis we're having, saying that, our police and fire departments are putting an enormous amount of their budget into managing the fallout of untreated addiction and homelessness and these types of things, much like our good judge up here is talking about. From a community perspective, if we're just looking at pots of money, it seems like that's a huge pot of money. Would it make sense to treat those people as opposed to send our police and fire to sort of clean up a mess in our city?
So yes, and I also think that there are ways, particularly fire can really help. I don't know where you are right now in Spokane with this, but in some areas of the state, we have paramedics actually starting people on buprenorphine in the field. That's great. And then you need a place to take them next that is actually welcoming and will continue them on that. But that is something where fire can immediately intervene and help stabilize them and help them feel better physically, not be in withdrawal. It provides them immediate overdose protection. So that is a thing that can happen. And then trying to build out those referral pathways so that fire can connect with folks. I have a grant right now in Seattle to build kind of a post-overdose recovery center to which fire can transport. So we're working on building that out. I think being really careful and thoughtful and judicious about how to use law enforcement. I think there's so much trauma and reactivity that happens that if we can avoid would be really worth it. And at the same time, I'm also mindful of the complexity that fire also wants to feel safe, and they often feel like they need law enforcement there. I don't have easy answers for that. Those are complicated things to try to figure out, but I think really trying to figure out, can you have co-responders who might be people with substance use expertise, social work expertise, who can really engage with people appropriately, often when they're in the midst of a withdrawal or a behavioral health crisis, making sure you're really bringing the right people to that kind of crisis event, and then figuring out how to take this acute situation and start initiating what is a chronic care for folks. And that's the challenge. The police and fire and emergency departments are used to responding to crises. And it is a crisis in the moment, but just fixing that crisis in the moment or putting a Band-Aid on it is not enough in and of itself. We need to figure out how to tone things down so it's a more productive initial interaction, and then transition people into supportive care in an ongoing way.
Yeah. It makes me think about here in the Spokane area, we have this new Spokane, County Stabilization Treatment Center. And my understanding is that the police or fire can take people there and they can, instead of going to jail, I think, something about it, something like that. You guys are nodding your heads like, yeah. Do you work there? No? Okay, so, I was thinking, so this has been one of the city's initiatives. My understanding is to try to divert people from being taken to jail, which seems like a better alternative than going to jail. I hope that the patients there are being offered medications for opioid use disorder while they're there in effective treatments. And I called over there to see if you could just roll up. Can you just walk over there and get on buprenorphine? And they don't take walk-ups. I think you have to be brought there by the cops. So, yeah. What do you know about? You seem like you know. No, you don't?
I have known someone who's gone through that process.
Yeah.
And has benefited from that process. But I think we do have to be escorted with some legal ramifications tied to that situation.
I did have a question, though, because I've been learning recently about Joel's Law, and I was wondering from an epidemiological standpoint, is there any data that shows, are these DCRs involuntarily committing someone? Is it working? Is it not working? Because I was wondering why there might not be a DCR at the stabilization center, or why there's only one in Spokane. Like, does that process work? Is it a lack of DCRs? Does it not work? Is it even being studied?
I don't know, if people here know about Ricky's Law or Joel's Law. Some of you may or may not know these, but these are laws that they're related to civil commitment, involuntary treatment for substance use disorder, Ricky's Law. And the problem that we run into in Spokane is that there's no place for them to go. That's my understanding, is the number of these beds are very limited. So the residents are shaking their heads that you can't. So you could detain someone, but there's no place, a locked facility to take them. And then you could also make that argument, the data for treatment against people's will isn't great in comparison to voluntary treatment. And so that's another dynamic about that. And Joel's law has to do with a family's right to ask for a second look after the DCRs have said no. And so that's another strategies that desperate families can look at. Does that answer your question?
I guess I just didn't know if that process has been proven to be successful or not, or if it's even being studied.
Do you know about the data?
Well, on Ricky's law, I know that it's implemented very inconsistently across counties. So that's an important aspect, is it's a lot of discretion, and it really also depends on access to services. I think part of the real challenge is that, you can make an argument that anybody using fentanyl is in grievous harm. I don't think we're ready to provide treatment to tens of thousands, housing and medical and evidence-based services to tens of thousands of folks. So it's getting implemented in the margins and very rarely. So I just don't think we have a good evidence base. What we do have an evidence base is we don't have the capacity to take it to scale. And I think the way I often think about it is I understand the desire 100% to help a person who is perhaps in mortal risk get care. But we don't have enough care for the people who want it. So the idea of depriving a person of their civil liberties and involuntarily committing a person without first having made access to care for everybody who does want it as a policy decision seems like a strange one. If you've got 95% of people want care and can't access it, let's start with the people who want it and save that last part for the people on the margins. Sometimes what happens from a policy perspective is we start making that the default response. We're going to involuntary treatment, you'll hear this a lot in different communities, like, oh, well, we're going to force people into treatment. Well, one, it's not available. Two, it's not effective. And three, as a society, that seems like a reactionary thing as opposed to actually looking at what is the actual evidence and what is the self-expressed need by people. We have not yet made the services available that people already say they want. So that's what my work is really around how do we make low barrier accessible care available to as many people as humanly possible. So I'm pivoting to what we are doing, what I know does work.
Actually, a couple of things. One, DCR stands for Designated Crisis Responder, and in Washington State, that's how people can be detained involuntarily. I don't know if everybody knew the initials. And we have an online question, or a comment probably, that at Sacred Heart Medical Center Emergency Department, we prescribe substance use disorder meds for substance, I don't know what STARS stands for. STARS daily?
Spokane Treatment and Recovery Services.
There you go. Substance what?
Spokane Treatment and Recovery Services, it's an acronym for STARS.
Okay.
So they're a local treatment.
Yeah, so Sacred Heart ER.
Yeah.
So.
Yeah, I think it's great. The emergency rooms are available. And I think you could argue that that's a pretty expensive way to provide care. I don't know anyway. I just think it's an expensive way to do something that could be done in an outpatient visit.
It's great that it's available there. It's wonderful, and nobody wants to go to the ER. So that's important as I look at an ER physician.
Think about how long you have to wait, right?
So.
Thank you. I have a question about the availability. If some of the treatment prescriptions can be obtained 24 hours a day, is there a pharmacy that can fill them? And I assume that I think I know the answer, but I won't make a comment.
So just a couple of things on that that I'm aware of. So one is that there is this 24/7 buprenorphine hotline right now that's in King County. The state has funded that. It'll actually be launching statewide, I think starting in January. We have a project to actually expand capacity for youth, and particularly having designated people to do a lot of the follow-up work with families. So that's it in terms of actually getting the prescription. There are a fair number of pharmacies out there, and I will note I've just been in conversations with Safeway Pharmacy, no conflicts of interest, but I will note I've just been in conversation with Safeway Pharmacy. They also are having pharmacists administer the long-acting injectable forms as well. I don't know if the pharmacies are doing that here locally. I'm seeing a nod of the head. So there are actual access points like that. I don't know that the Safeways are open 24 hours, but there is a really growing access in terms of both the prescription and access to the medications. Is there more that you?
Yeah, I know that there is at least one pharmacy in Spokane that's open 24 hours. I think it's in the valley. Now, but Caleb's saying
For
that
now.
it's going to be coming in January.
Things happen. Yes, Leilani. Leilani is my colleague from the University of Washington. She's not a plant. She's just a very knowledgeable person.
I'm just here being supportive. Don't call me out like that. I do know of a provider that works at the 24-hour abuse hotline who has received calls from Spokane and has been able to help them. They're not going to turn anybody away, but it is King County funded.
They're not advertising it.
Yeah.
But
In terms of licensure, as long as you're licensed in the state where the patient is located, you are allowed to prescribe medications for them and care for them.
This may seem like a super uneducated question I should know the answer to, but on occasion, we've had a parent that's come to stay with us that's brand new, that has missed an appointment at the methadone clinic or something like that, and then all of a sudden it's, Sunday at 12, and they're not allowed to, am I understanding that correctly, that like if you are getting your prescription at one clinic, you can't go to another, or are the ERs, we were under the understanding that the ERs were not an option.
I'm seeing nodding from people is that correct, that the ERs are not going to fill somebody's missed methadone script or dispensing?
Another complicating variable in that is that as prescribers, we're unable to see the dispenses from methadone clinics. And so as a prescriber in the emergency room, I could imagine a situation where the patient says, I didn't get my dose today. And you're like, oh, did they or didn't they? And it can be really scary. Like, am I going to kill this person? And so it's a really dicey situation. Now, so it's a little trickier for methadone because of the regulatory issues that we talked about. Buprenorphine is a lot more, less complicated.
We have another online comment here. In Sacred Heart, we bridge people with methadone doses in the ER. They just have to come in each day, which is typical for many methadone clinics or daily dosing until patients have been established for a while.
Yeah, and I'll note there are ways to get people started on methadone who are not in an opioid treatment program for up to 3 days. Emergency departments could initiate that, hospitals could initiate that, other settings could initiate that. It's not common, but it is allowable.
All right, so if there's no other questions, I think we'll thank you two so much for your presentation and your work on this. I mean, truly incredible. I think really good work. And then also, supposed to thank our sponsors too, Providence Multicare, Spokane County Medical Society, Spokane Regional Health District, and the UW Population Health Initiative. And then I'm going to remind you all that we'll send the links to the video recording later this week. And if folks are online, we'll be sending that to you too. So thanks again. Amazing work and just, really inspiring. Thank you.
Thank you.